So we're going to wrap up with this last presentation with Dr. DeAnna Baker-Frost, and she's an assistant professor in rheumatology and immunology in the College of Medicine at MUSC. She's doing some fabulous work, research that she's going to share with you. And she's also going to bring to you the 5 most common questions she's hearing from patients. So Mike might touch on some things you've been curious about or wanted to know about. So welcome, Dr. Baker-Frost. We are so delighted to have you. Take it away.
Great. Can everyone see my slides and can everyone hear me okay?
Yes.
Okay, perfect. So I am so excited to be here today to talk to everyone about the top 5 questions about scleroderma. So the first thing I want to talk about is how did we even determine what these questions are? And so because this is, a patient education event, I wanted to talk to our patients to make sure that whatever questions that we talk about today are questions that you find that are most relevant. And so I want to give a big thank you to the South Carolina chapter of the National Scleroderma Foundation, specifically the Charleston area chapter. I sent out an email to our co-leaders, Patty Newman and Sarah Budd, and they polled our support group to see what questions that they thought were most relevant that we wanted to talk about. And so based on the questions that I received, I kind of separate the questions into 5 big themes, addressing those questions and maybe some other questions that may come up in those themes as well. So again, thank you very much to the South Carolina chapter of the National Scleroderma Foundation and our support group leaders, Ms. Patty Newman and Ms. Sarah Budd. Okay, so here are a couple of the first sets of questions that we're going to talk about today. The first questions are, what are the latest thoughts about genetic factors in developing scleroderma? And then another question that was submitted is, what do we now suspect about specific environmental triggers for scleroderma? So when I kind of looked at those 2 questions together, what I thought about, hold on one second. What I thought our first kind of theme that we could talk about is like, what is the cause of scleroderma? This is a very common question that most rheumatologists will get for kind of overall, what are the causes of autoimmune diseases? Why do patients develop these diseases in the first place? And so the way that we think about autoimmune diseases, even scleroderma, is we think that it's a combination of genetic factors and environmental causes that come together and cause a patient to develop scleroderma. So we know that genes alone don't cause scleroderma. Dr. Pagali-Bostwick and others several years ago did some fantastic studies looking at twins that have one twin may have scleroderma, the other twin may not have scleroderma. And if you guys are aware, identical twins have the exact same DNA, so they have the exact same genes. So you would expect that if identical twins, if one twin has scleroderma, the identical twin would also develop scleroderma, and that just wasn't shown in the research. So there is not a 100% inheritance of one person having the disease and one person not having the disease. And you can see that sometimes in family members as well. So you can have one family member that might be affected with scleroderma, and other family members may not be affected with the disease. But we do think that there is a genetic contribution that does happen. So there are genes that are activated and that can contribute to the changes that we see in scleroderma, specifically genes that affect the immune system and genes that affect blood vessels and genes that affect skin cells and lung cells, which is a lot of the research that's kind of going on now to understand what those genes are. And as Dr. Silver alluded to, Dr. Paula Ramos and others have been looking to see how the DNA of our patients with scleroderma can be modified that can also maybe predispose them to scleroderma. So we think that there is likely a genetic predisposition, meaning that there are some patients that are more likely to develop the disease based on some things in their genes, but we don't think that it's purely the genes that lead to scleroderma. There are some known environmental triggers, however, that can allow someone or that can cause someone to develop scleroderma. So there's been several studies to show that people who are exposed to crystalline silica and different types of organic solvents, the types that are used for dry cleaning and for paint thinners and some nail polish removers and then glue solvents and spot removers, they can go on to develop scleroderma based on these occupational exposures. There are also some studies to look at fumes from welders. They can go on to develop scleroderma as well. And then there's also some other research that we're trying to understand how heavy metal exposures can also lead to the development of scleroderma, including arsenic, cobalt, lead, manganese, mercury, tin, antimony. So we're still trying to understand how all of these environmental triggers in conjunction with kind of the genetic predisposition can come together to cause a development in scleroderma. So the next sets of questions really have to do a lot of the symptoms that, that our patients are subjected to when they develop scleroderma. So some of the questions that we received were, does scleroderma exacerbate dry skin? Does it dry out the skin elsewhere in the body? When the skin thickens as a result of scleroderma, does it hurt? Is it true in general that symptoms are not as severe in patients that are developed later in life versus those that are developed earlier in life? And then someone was asking questions about kind of the GI manifestations that can happen with scleroderma and how those GI manifestations are similar to IBS or different from IBS. And so kind of taking all those questions in general and kind of putting them together, I want to kind of talk now about kind of what are some of the symptoms that one can expect when they're developing scleroderma, when they do develop scleroderma. So as you all know, you don't need me to tell you that there are several hallmark symptoms that most people who have scleroderma may experience, such as skin disease and skin thickening and tightening. There are also GI manifestations and GI discomfort that can happen. And then there's the interstitial lung disease component that can happen with scleroderma. So, you know, when we're talking about the skin symptoms related to the disease, and the question was, is skin thickening painful? Skin thickening can be painful because of what it leads to downstream. So sometimes patients can develop skin thickening to the point where their fingers can become flexed and bent in a fixed position. And so that can be very uncomfortable when that happens. And sometimes the skin can become so thick that it can also affect the muscles beneath the skin. And those muscles can become very fatigued and weak because of the skin thickening that can take place. So we also have little nerves in our skin that can be activated and irritated as well because of the skin thickening that takes place. And even sometimes when the skin becomes thickened, pressure ulcers can develop, especially kind of on the knuckles and on the fingertips. You guys are more familiar with that. But that can also occur because of the skin thickening as well. And dry skin can occur in scleroderma. I often tell my patients that this time of year is pretty much the worst time of year because you have decreased humidity due to the cold weather that can lead to dry skin. And then you have scleroderma that can also exacerbate dry skin. And so moisturizers are key. And so I just put some moisturizers that I often recommend to my patients. So CeraVe products can be very helpful. Aquaphor can be very helpful. You're really looking for moisturizers that are pretty heavy, that can kind of really seal in the moisture to try to prevent as much dry skin as possible. And then sometimes, you know, despite all the, you know, things that we do with over-the-counter products, we really lean on our dermatology colleagues. And we have a fantastic group of dermatologists at MUSC that we refer to quite often. And if we're having real issues controlling the skin symptoms and the dry skin with moisturizers, then we can always refer to one of our dermatology colleagues to see if they can be a little bit more helpful in recommending some products as well. Now, if we're talking about the GI manifestations or GI symptoms that's kind of related to scleroderma, I wanted to kind of look separately at our GI tract in total. So we have our little man over here. And so it's separated into the upper GI and the lower GI. So the upper GI, I'm sorry, yes, the upper GI shows the pharynx, which is the beginning portion of the mouth here, and the esophagus and the stomach. And a lot of the upper GI symptoms, you can have acid reflux symptoms, which I know a lot of patients suffer with. And we use a lot of proton pump inhibitors or PPIs to help kind of manage those symptoms. But then oftentimes the lower GI tract can also be affected by scleroderma as well. And so that includes the large intestine, the rectum, and the anus. And when that lower GI tract is affected, some of the symptoms that can occur include constipation, diarrhea, bloating can happen, weight loss can occur, and vomiting can occur. And oftentimes, unfortunately, some people may have both upper and lower GI symptoms because both the upper and lower GI tract can be affected by the disease. Now, when we talk about irritable bowel syndrome or IBS, patients that have IBS can have some of the very same symptoms that patients that have scleroderma can have. And so the symptoms can look very similar in that they can also have weight loss. They can have rectal bleeding because of persistent diarrhea. They can have abdominal pain. They can also have recurrent vomiting and nausea. And due to the recurrence of the vomiting and nausea causing bleeding, they can have anemia as a result of it. So unfortunately, if a patient has both scleroderma and IBS, it can be really difficult to differentiate which symptoms are related to the IBS, what symptoms are related to scleroderma. So that can be difficult to tease out which is caused by which. However, there are similar medications that can be used to treat both diseases. So if someone has scleroderma and IBS, some of the same medications can be used to treat both diseases. And there was another question about kind of differences in symptoms based on age. And so the question was if there are less severe symptoms later in life compared to earlier in life. And kind of me looking at the research over the years of scleroderma, I did not see that the symptoms are less severe later versus earlier. They're more so different depending on the time in which you were diagnosed with the disease. And so those who were diagnosed later in life with scleroderma, they tend to have a higher prevalence of being diagnosed with the limited form of the disease as opposed to the diffuse form of the disease. Now, that is not 100%. I have several patients, as well as I'm sure my other colleagues have several patients later in life that's been diagnosed with a diffuse form of the disease, but there does tend to be a higher prevalence of limited scleroderma in later disease. There is also a higher risk of having kind of coronary artery disease or heart disease that can occur with scleroderma, as well as pulmonary hypertension and systemic hypertension. Those who are diagnosed earlier in life with scleroderma, they're more likely to have more digital ulcers. They're also more likely to have muscle inflammation, which is also called myositis. They're also more likely to have more esophageal involvement or more of the upper GI involvement. And again, I say this is by and large, just kind of looking at the overall data. Those who are diagnosed later and earlier in life can have an overlap of these symptoms as well. But I think the large point that I'm trying to make is that just because you're diagnosed with the disease later in life doesn't mean that you won't have severe manifestations, or just because you're diagnosed early in life doesn't mean that you're doomed to have severe manifestations. It really just depends on kind of how the disease presents in each individual person. So the next set of the submitted questions that I received was more so looking at the progression of scleroderma and kind of what to expect as the disease progresses. So the first question is, scleroderma is classified as a progressive disease, but is it always progressive? Are there patients whose symptoms remain stable or even improve over time? The next question was, what can I do to stop the progression? One person was concerned about the function of her hands and was wondering, would she lose function in her hands? Another question was, is there any way to predict who will get telangiectasias, and can they develop at any stage of the disease? And then the final question is there a difference between progression of the disease in younger patients versus older patients? So the next set of kind of questions obviously has dealt with the progression of scleroderma. So I thought we could take some time to talk about that a little bit. So this was a graph that was done by Dr. Metzger at the University of Pittsburgh several years ago. He was a fantastic clinician and researcher and dedicated his life to scleroderma research as well. And he kind of laid out what the progression of scleroderma could look like. And this was more so looking at skin thickness, which is located here, and then kind of disease duration, meaning the number of years that a person had a scleroderma. And so as Dr. Soper kind of alluded to earlier, like it's kind of been broken down into 5-year, 10-year, 20-year time periods, because we tend to think of the 5-year time period as the time where we start to see kind of some improvement with the skin symptoms. So as you can see, if we're taking a person that has diffuse scleroderma, early on, prior to 5 years, you'll see this kind of increase and kind of rapid skin thickening occurring. This is the time when most of those clinical trials are trying to recruit patients, because this is the time when we think that there's a lot of disease activity that's ongoing. This is also time when there's concern for involvement of the other organs, such as GI manifestations as we've talked about before, interstitial lung disease, possibly scleroderma renal crisis, which we'll talk about a little bit later, as well as heart disease. And so during this first 5-year period of time is where we're concerned that all of these things are happening and you have a kind of rapid progression of the disease. However, when we kind of pass that 5-year time point, we kind of see that the skin thickness starts to taper off, and you don't see as much concern about these other manifestations. Now, again, we will always monitor, and we're always looking to make sure that there's no new organ manifestations that are occurring in our patients. However, the earliest time point that we're concerned about this is kind of in the beginning of the disease. Now, when we're looking at someone who has limited disease, again, early on, you may see some increasing of skin involvement, not as much with the diffuse patients, just by definition of the manifestations of a patient that has limited disease. But then something different happens after the 5-year time point for a patient who has limited disease. Now we're seeing kind of more concerns for pulmonary hypertension in these patients, also some malabsorption or GI manifestations that's happening later in time for a limited patient. So sometimes the progression of scleroderma can really be differing depending on the type of disease you have, whether it's diffuse disease versus limited disease, and also the duration of time in which you've had the disease, in that we are thinking that diffuse patients might be more active earlier in time, while our limited patients may develop kind of more symptoms later on in life. And there's other factors that we looked at that we are concerned about as well. So we've already mentioned that diffuse patients and limited patients, we're concerned about different manifestations of their disease to help to predict whether their disease will progress or not. So our diffuse patients, they're at a high risk for developing something called scleroderma renal crisis, which is what we call one of our rheumatologic emergencies, and that patients will develop very high blood pressures that could damage their kidneys. And so we always recommend for our diffuse patients to monitor your blood pressure on a regular basis and contact your rheumatologist as soon as possible if you note that the bottom number or the top number is sustained high for a period of time, so you can start medication. Our diffuse patients are also at a risk for interstitial lung disease. Again, limited patients can also develop these manifestations as well. When we're thinking about kind of progression of disease, we really want to pay attention to these two entities in our diffuse patients. However, as the graph showed before, patients with limited disease are also at risk for pulmonary hypertension. And this is where the telangiectasias will come in, because oftentimes as people will develop pulmonary hypertension, sometimes they can have more telangiectasias that will become more prominent. And for those of you that aren't familiar with telangiectasias, they're dilations of the blood vessels that can be seen on the face, it can be seen inside of the mouth, it can be seen in other organs. And so sometimes they become more prominent as people go on to develop pulmonary hypertension. Sometimes based on how someone's autoantibodies profile can look like will kind of help us to determine progression of disease. And so if patients are positive for certain autoantibodies versus another, it makes us more concerned that they could go on to progress and develop scleroderma renal crisis or interstitial lung disease. And as we mentioned before, the age of the age at which diagnosis occurs can also help us to differentiate kind of progression of disease at times. But as I mentioned before, we don't take anything for granted. So we're constantly monitoring our patients for progression of disease, which means that we're doing our pulmonary function test, which monitors for interstitial lung disease on a regular basis. So depending on if you have diffuse disease or limited disease, your autoantibody profile, your time in which you were diagnosed, your rheumatologist will determine how often you should have these pulmonary function tests performed. We also do regular echocardiograms to look for pulmonary arterial hypertension as well. And again, based on the things that we talked about before, your rheumatologist will help to determine how frequently you should have the echocardiogram performed as well. And so we found that if we are constantly monitoring for disease progression, then we're able to detect it early and then we're able to get our patients on treatments as quickly as possible. And so one of the questions was, what can I do to help to slow the progression of disease? And so, we've talked about lots of different clinical trials that are out there and the development of research opportunities that are out there to try to find better drug targets for our patients. But there are also some non-pharmacologic therapies that could also be helpful for disease progression as well. And so we always try to get our patients into occupational therapy. So they've been shown to be very useful in helping to preserve or improve hand dexterity or any other type of dexterity in our patients due to the skin thickening that's taken place. I think several years ago, for one of our patient education events, we did have one of our occupational therapists that gave a fantastic talk about the benefits of occupational therapy. So that's one of the non-pharmacologic treatments that we always recommend. Pulmonary rehabilitation is also very useful at times. It can improve exercise tolerance once you're on the proper medications if necessary for interstitial lung disease. Pulmonary rehabilitation can also be very helpful to kind of open up any other lung areas so that you're maximizing your lung potential as much as possible. And then for GI symptoms, sometimes probiotics can be helpful. But again, before taking any probiotics or any other type of supplements, I would definitely talk to your primary rheumatologist to make sure that that would be a supplement or a therapy that could be useful. But probiotics can sometimes help improve some of the GI manifestations as well. Okay, so one of the next questions it broke my heart when I saw this question, but it's a real question that our patients will often have. And the question was, is this disease going to kill me? So the question, I kind of interpret that question to mean, what is the survival for our patients with scleroderma? And I think once you find that you have that diagnosis, that's definitely a question that is running through your mind. And sometimes you'll see things on the internet. If you Google scleroderma, you can see things that are very concerning and very frightening at times. And so I'm sure that that's a question that often comes up. So this is like some statistics about kind of patient survival. So currently, the leading cause of death in scleroderma is due to pulmonary involvement, which is interstitial lung disease, but also pulmonary arterial hypertension. At one time, it used to be a scleroderma renal crisis, which is the disease that, or the manifestation I talked about earlier, that causes a very high blood pressure, that causes the kidneys to shut down. However, with the advent of new medications called ACE inhibitors, lisinopril is the name of the medication that some of you may be really familiar with, we've seen the rates of people succumbing to scleroderma renal crisis plummet. However, we're now seeing increases in deaths from scleroderma related to pulmonary involvement, which is interstitial lung disease, and pulmonary arterial hypertension. So the mortality rate was increasing from 1968 to 2000, but we have started to see a decline, specifically looking at the years from 2001 to 2015. That's the latest data I could find in 2015. And we really think that this improvement in survival has been related to advances in medications and research surrounding scleroderma, such as treatments for pulmonary arterial hypertension, interstitial lung disease, and renal crisis. However, we still do have some work to do. We do find that women and African-American persons that have scleroderma do have higher mortality rates compared to men and white persons. And so I put a little graph here on the side to kind of show the differences in mortality with these two groups. So here is, we consider this as survival. And so this one here means 100%. That means 100% of the patients survived and did not succumb to disease. And here is kind of the years out from visits. And so if everyone survived, this line should be straight across no matter how far they're out from their first visit. The green line depicts non-African-American patients, and the blue line depicts African-American patients. And so as you can see, there is a separation between the two lines. So you have non-African-American patients here, meaning that they do have a higher amount of survival compared to African-American patients that have a lower rate of survival. And the differences between these two lines is statistically significant. So that means that is a real difference. And so now we're really trying to understand what are the contributions and that's causing this difference between survival between these two groups. But the encouraging news is that we do see a decline. We do see an improvement in patient survival and a decline in mortality related to scleroderma. So that's very encouraging. The next set of questions here have to do with kind of research and curing of the disease. So the first question is simple: is there a cure to scleroderma? The next question is also related to that. It's also classified as incurable, but I've seen people online claiming to have been cured of it. Are there any verifiable cases of that occurring? And then the final question is this illness potentially one that could someday be addressed through gene editing? And so kind of the final group of questions I wanted to talk about is, what is the current and future treatment options for scleroderma? So all of these medications are probably very familiar to you, and we have talked about some of them in this meeting here, including Cellcept, methotrexate, lisinopril, amlodipine. All of these medications are well used in scleroderma for lots of different purposes. We also have infusion medicines and injectable medicines that have also been used, and that we can now also add into our practice in treating patients with scleroderma. But I want to touch a little bit on stem cell transplant, because I think that might be one of the options that you may not be as familiar with. So first, there are no known cures for scleroderma. However, stem cell transplants are something that we've been looking into a little bit more. And there was a study that was published in the New England Journal of Medicine that compared patients who underwent a stem cell transplant to those patients that received cyclophosphamide or Cytoxan. So let me back up for a second and kind of talk a little bit about a stem cell transplant. And so there are two different types. So there's one that's called autologous, which means that you isolate the cells from your own body, the stem cells from your own body, and then can kind of give it back to yourself versus getting a stem cell transplant from another person. So this study was looking at autologous stem cells, which means that the stem cells was isolated from the person's body. Then the person's immune system was completely depleted with medication. So it completely wiped out their immune system. And then those cells that they isolated was given back to the person and let those cells kind of repopulate the immune system. And so for those patients that was able to tolerate a stem cell transplant successfully, they did show that they have improved skin thickness, they had decreased organ involvement. And so it looked very, very promising, that it was very helpful to a lot of patients that were able to undergo that treatment. And so there are some of our patients that did successfully have a stem cell transplant, and a lot of their manifestations of scleroderma are gone because of that. And so I think some of the information that could be seen online about cures for scleroderma could be related to kind of the stem cell transplant aspects of things. However, I will say there are other types of supplements that are out there that have been touted as possible cures for scleroderma, but other than stem cell transplant, there are no other medications that we know of that have been given to a person to cure the disease. The other question was about gene editing. And so this is another fascinating area of research in medicine that we are looking closer into as well. So gene editing basically is finding the problematic gene in your body and giving yourself a newer, better copy of it so that it prevents the disease from occurring. And so this has been useful in some diseases, especially diseases in where we were able to find the gene that was problematic and to fix it. However, in scleroderma, we haven't found that one gene that is problematic. Kind of going back to my first slides that we talked about, we really think that scleroderma is a combination of genetic and environmental factors. So at this point, we haven't found that smoking gun or that one gene that we think is problematic that gene editing would be useful for. However, there's lots of research that we're still undergoing right now to understand which genes are the genes that are interesting, that could give us a lot more information to other genetic causes to scleroderma. So this is a great segue to talk about kind of my research, since we're ending on research. And so what I thought I would talk to you a little bit about now is what I've been working on in my research lab and the focus of the National Scleroderma Foundation New Investigator Grant that I was awarded. So my research is really based on estrogen and really trying to understand how estrogen can play a role in fibrosis, and to determine if we can block the signaling of estrogen as a potential treatment for scleroderma. And this came from several observations. And so one big observation is that more often than not, women are diagnosed with scleroderma more often than men. And one of the biggest hormonal differences between women and men is estrogen. And several years ago, my mentor, Dr. Fagali Boswick, noted that if she gave estrogen to some of the skin cells in scleroderma patients, as well as in healthy controls, that it would produce lots of proteins that can cause fibrosis to occur. The other interesting thing is patients with scleroderma also have very high levels of this protein called IL-6. And IL-6 is a protein that can cause inflammation, it can cause fibrosis, and it can also activate aromatase, which is the protein that can make estrogen. And we published a paper about a couple years ago as well, showing that patients with scleroderma have very high levels of estrogen, in addition to having high levels of IL-6. So that got us to thinking, does IL-6 and estradiol or estrogen have a role together, and do they both work together to cause fibrosis to take place? So my overall research goal is really to understand how estrogen can cause fibrosis. And my plan is to look in the cells from scleroderma patients and patients that are healthy to compare how the cells respond to estrogen to lead to fibrosis, to look at the transcriptome, which is another name, to look at the genes and DNA to see how those become activated to cause fibrosis, and then to look systemically and measure kind of estrogen levels of patients with scleroderma and try to correlate that with clinical outcomes like interstitial lung disease and GI manifestations to see if that's a relation to causing fibrosis as well. So as a part of this research grant that I received from the National Scleroderma Foundation, what my plan is to study the direct effects of IL-6 and how it will produce estrogen to cause fibrosis. Well, this is my little skin cell here. And so this is IL-6 binding to its receptor. And the thought is that it will cause aromatase, which is the protein that makes estrogen, to cause the cell to produce estrogen and then go on to make fibrosis. And so the purpose of this whole project is to really understand how this pathway takes place. And if I could block any point in this pathway to prevent fibrosis from taking place. So in order to understand this better, we're going to use several different models. So we're planning on using human skin cells from healthy donors, as well as patients from scleroderma. So I want to thank those that have been so kind to have allowed me to do skin biopsies on them thus far and grow their cells in my research lab. So I greatly appreciate that. And so from those cells, we're going to look at the proteins and the genes that are involved in fibrosis. We've also been able to get a collaborator from Northwestern University in Chicago who has mice who actually have this human copy of this gene. And so we're going to use those mice to also understand how skin fibrosis takes place. And between using those two models, our plan is to demonstrate that estrogen production directly causes fibrosis, and hopefully to show that if we can block the signaling of estrogen, then it could be a potential treatment for fibrosis. So again, I want to thank you guys for listening to my talk. Thank you guys for submitting questions to me, and I'm more than happy to take any questions that you have.
Dr. Baker-Frost, that was fantastic. And we did have some great questions. I'm going to summarize them for you, and because a couple of them, as they came in, I can kind of group. So one question was about, I'm not sure if I'm going to pronounce this correctly, Actemra. Like the question was like, who takes it? You know, it has so many side effects. And then they asked, well, what are the benefits of CellCept?
That's a great question. And so Actemra is actually a medication that blocks IL-6 signaling. So that directly goes back to what we just talked about pertaining to my research. Because patients with scleroderma have very high levels of IL-6 circulating, and that IL-6 can cause fibrosis and inflammation to occur. There have been several studies to show that if we give patients Actemra to block that IL-6 from working, that it's the potential treatment for specifically interstitial lung disease. There were trends to show that it could be helpful in the skin disease, but it's been FDA approved for interstitial lung disease specifically thus far. And you know, I know that our medications have lots of side effects, unfortunately. And so, you know, that's where it becomes a really important discussion with your rheumatologist to understand kind of what your manifestations of the disease is for scleroderma, and to understand if, you know, starting a medication with potential side effects outweighs the benefits or outweighs the risk. So it's a risk benefit kind of conversation to have. Cellcept, on the other hand, is an immunosuppressive medication as well, I should say. So what it does is we think that it decreases the functioning of T cells, and T cells are a part of our immune system to cause inflammation to happen as well. And so prior to approval of Actemra or of any of the other medications, it was shown that if we compare patients with interstitial lung disease and scleroderma who take Cellcept compared to those who don't take anything, or those who take Cytoxan or cyclophosphamide, those patients with Cellcept can have an equal improvement of their interstitial lung disease as those taking Cytoxan, but it's often better tolerated than Cytoxan is, because Cytoxan can have lots of different side effects for that. So oftentimes we screen a person, at diagnosis, or we're constantly doing our monitoring, and we find that they have significant interstitial lung disease. One of the first medications that we will try is Cellcept to try to prevent worsening of the interstitial lung disease. It can also be helpful for skin disease as well. So there are often times where we would use Cellcept when patients have severe skin thickening and tightening. Cellcept can be helpful for that. And even myositis or muscle inflammation, Cellcept can be used for that. So it can be used in a number of different arenas for the manifestations of scleroderma.
That's fantastic. And some of this is going to probably come up in our Q&A in a few minutes, because I can see questions percolating up as you more talks, like, well, what about this? But I did want to make sure I answered the ones that came up during your talk. So there were two questions from two different folks about other causes. And so one person asked, can stress cause scleroderma? And the other, can viruses trigger scleroderma?
Those are also very good questions as well. I have not seen any studies that stress directly can cause scleroderma. And there's also still been some research out there looking at different viruses, and viral particles could have induced scleroderma as well. So far there hasn't been a direct link to any one of those entities causing scleroderma. I often tell my scleroderma patients, or any of my patients as well, stress is not good for anything, especially your autoimmune disease. And so even though it may not necessarily cause the disease, it's not a good practice to have stress in your life. Easier said than done, I know. But
yeah.
but trying to minimize stress as much as possible is always beneficial. But no, there hasn't been any direct link to stress or viruses causing scleroderma yet. Anyway, I always say yet.
That's right, because so that's what we know at this point, and I think probably it's more related to, like a next step away, like making your inflammation system just overactive. So your immune system is already a little confused about what it wants to attack. You don't need to poke the bear and make it ramp up, right? Keep the stress level down, keep inflammation down. So there was another question about medications for pulmonary hypertension, and kind of leads back to this idea of side effects. So the question basically was like, how long do you have to take or be on these pulmonary hypertensive medications, and do they cause other problems like other organ damage when you've been on them a long time?
That's also a very good question as well. I tell patients that we're in a great time in rheumatology, because we now have medications to treat these manifestations. When 20, 30 years ago, we didn't have these medicines, unfortunately. And so we're very grateful to have them. And so we're able to, watch our patients improve. Now we're at the point of trying to understand if ever we could stop any of these medications, and if they would cause worsening side effects or a recurrence of the disease. And unfortunately, we don't have the answers for that yet. We don't know if we're ever able to stop these medications, and if that would cause kind of worsening of disease to occur, or any other organ manifestations to happen. So I often tell my patients, we're learning together. We know that these medications work. We know that they're helpful, but as to if we're ever able to stop them, then we're not at that point yet to know. There's studies out there in other diseases that are looking to understand if we're able to kind of not calm down, but stop any of the disease modifying medicine, specifically in rheumatoid arthritis and a little bit of lupus. We're looking at that as well. So we honestly don't know the answer to that, unfortunately. And, you know, as we're using these medicines longer, we're monitoring for potential issues with other organs or other side effects that can occur with the medication. So unfortunately, I don't have an answer to that question, other than that we're watching and we're reading and we're kind of looking at the literature together to understand if we're ever able to stop them.
So there's no clear, there's no easy answer. So just have to keep talking with your healthcare provider to watch and, make decisions.
Exactly. It's an open communication. Yes, it's an open exchange of communication. And if you're ever concerned, talk to your rheumatologist about it so that you can get, as best of an answer as you can get prior to kind of like stopping medications. Just kind of, always have that line of communications open. We're always happy to talk to our patients about those kind of things.
So another question came up about CellCept, and then there was something related to estrogen. So I'll try to wrap that up. And then we'll switch gears. We'll just open some questions up because we'll have more, but we'll just transition. So one participant asked, is mycophenolic acid helpful like CellCept?
Mm-hmm. So it is. So mycophenolic acid it's not CellCept itself. They're both the same medication. So if you look at CellCept, the generic name for CellCept is mycophenolate. And then there's another form of the medicine called mycophenolic acid, or Myfortic is the brand name. And so they're both very similar medications. However, Myfortic or mycophenolic acid is enteric coated. So it has a coating around the pill that we sometimes will have to use, especially if patients are experiencing a lot of GI side effects related to the original CellCept medication. And so if you are finding that you are having those side effects, then we will switch you to the other form, the mycophenolic acid, which is enteric coated, which will help to hopefully prevent some of those side effects from happening. But other than the enteric coated, then they're very similar medications, and we think that they work equally as well for skin disease and lung disease and muscle inflammation.
So this is the last question before we transition, because there'll be more. So this is a grouping in the questions relating to your research with estrogen. So that's definitely sparked some curiosity. So there are 3 questions I'm seeing related. So this is big. So you may not be able to answer all those, but just hear them because it's as a cluster. So one is related to puberty, and if girls have early puberty, is there more risk for scleroderma? The other one was during breastfeeding, which may affect estrogen. Could that have been protective against some disease? And then the third is this link between estrogen and breast cancer, and is a scleroderma patient more vulnerable to breast cancer? Woo,
those are all great questions.
That's like a semester class.
I love how everyone is so invested in the research, and thanks so much for those questions. Those are awesome questions, and I hope I can do justice to them. So as far as the age in which puberty takes place in the development of scleroderma, that is a great question, and we're not 100% sure. We do know that systemic sclerosis is uncommon. I should say is less common in children. So you don't have a lot of children that have the systemic form of the disease. They will have localized scleroderma like morphea, but they don't necessarily have the systemic form of the disease. However, when someone does go through puberty, you do see an increased development in scleroderma. So in the childbearing years for a woman, you will have a higher risk of them developing scleroderma compared to later in life or earlier in life. So that also helps us to wonder if estrogen levels is doing something to modify genes or something to cause someone to be more likely to develop the disease. But I have not seen any studies specifically study that's looked at the timing in puberty and the development of scleroderma. So I think that's a fantastic question.
That's an epidemiological study, right?
Yes.
Yeah.
Yes.
Yeah.
So that was the first question. Can you remind me of the second question again?
Yeah, so then
Karen?
there was during breastfeeding, when estrogen levels may be low, could that have been protective?
That's a great question also. It's again, it's hard to say to make that one-to-one correlation, because again,
Right.
we don't know if estrogen is the trigger for scleroderma. We don't know if that's that one trigger that could have led someone to develop or not develop scleroderma. So it's hard to say. The other caveat that we also have to remember is there are also kind of estrogens that are in our environment all the time. And so, we have foods that may have been modified hormonally. So you're getting some hormonal interactions from that. Some of the plastics that we use will also have some hormonal activity to them too that can activate our hormonal receptors as well. And so it's not just the estrogen that we're producing ourselves, we're also getting estrogen in our environments as well. And so both of them are likely playing a role into things, into the development or the development of scleroderma that I'm trying to study. So it's hard to kind of make correlations with, breastfeeding without knowing kind of the diet of the person and how many other estrogens the person is taking in their environment, in addition to the estrogens that they're making themselves. So it makes it a little bit a more complicated question because of that as well. Now, if we could kind of take a person and like feed them all the same thing in one place or expose them to the same environment, then it makes it a lot easier to kind of answer those questions. But as we're kind of all out living life, it makes it a little bit harder to answer that. So I can't 100% give an answer to that question, unfortunately. But I think it's a great thought that if we can lower our estrogen levels, would that be protective? And that's kind of what we're trying to get at with our research, is if we can block signaling, or if that would be protective or a potential therapeutic measure. So we will see. We'll see what happens with our research. And that's
the breast cancer one. Yeah, I didn't know if you needed me to remind you. That was a lot.
So the breast cancer one is also interesting. But I read a lot of breast cancer literature because they've done a lot of work with looking at hormonal-based cancers and understanding how they can affect the body. So, there is an entity that we are always concerned about with our patients, and that is scleroderma caused by what we call perineoplastic process, meaning that if a person has a cancer, is that driving the development of scleroderma to take place? And that could be any cancer. It doesn't necessarily have to be breast cancer. Any cancer that a person can develop can sometimes cause their body to develop an autoimmune disease like scleroderma. So I've not actually looked at the incidence between patients developing breast cancer or having both breast cancer and scleroderma at the same time. But I think that would be something extremely interesting and easy to kind of look into the literature to see if there is that correlation between the two, especially the breast cancers that are hormonally regulated, like those hormonal cancers that you would use estrogen blockade as helpful. There is a concern that some of the medications used for breast cancer treatment can trigger scleroderma. So there is some thought about that as well. And so we're really trying to parse out if someone who develops scleroderma and has breast cancer at the same time, is it related to their medications or not, or if that would have happened regardless of their medication. So again, trying to parse out causality can be sometimes difficult as well.
Thank you so much for you handled those great. The range of questions, and everybody, thank you for such excellent questions.